Hey, I think we should get started. So good evening, everyone. Thank you for joining us for the May lecture in our BSMS monthly lecture series. My name's Agatha, and I work in the outreach and admissions team at Brighton and Sussex Medical School. I'm just going to do a bit of housekeeping before we get started with tonight's talk. So just to make you aware, this lecture is being recorded, but you as members of the audience won't be captured in the recording. It will only be myself and the panelists. And you will be sent the recording a little while after tonight's webinar, after it's been edited and captioned, and the video will also be uploaded to our YouTube page. So you will be able to access this talk later. If you have any questions that you'd like to ask during the talk, please submit them via the Q&A function. You are able to upvote questions. So if you want to ask the same question as someone else, instead of putting it in the Q&A again, please just you can give a thumbs up if someone's already asked a question. So that would just be helpful. We can see which questions are the most popular. We'll have probably roughly 15 minutes at the end of the lecture to answer any questions you've submitted. But as we go along, if you have any kind of general questions pertaining to medical school, I can answer those in the Q&A, but any questions related to the talk and its content will be answered by our panelists at the end. Which just leaves me to introduce our fantastic speakers for tonight. So we are joined by Rachel Forss and Libby Rodriguez. Rachel graduated as a podiatrist in 1995 from the University of Brighton and completed an MSc in podiatry in 2003. Since graduating, she worked for the NHS at East Sussex Healthcare Trust for 18 years, 13 years of those as the wound care lead within the podiatry department. Since 2013, Rachel has been working at the University of Brighton and is now the course leader for the MSc Podiatry pre-registration course. Rachel has research interests in wound healing, exudate viscosity, and most recently, how microgravity conditions affect wound healing. Libby graduated as a podiatrist from the University of Brighton in 2018. She has since worked in private practices treating a wide range of conditions. Since 2022, Libby has been part of the University of Brighton and is currently the admissions tutor for the BSc Podiatry programme. Her interests include musculoskeletal conditions of the lower limb, biomechanics, and human movement. So, Rachel and Libby, thank you so much for being here with us tonight, and I will hand over to you.
Thank you very much. Hello, everyone. I'm Libby, and this is my colleague Rachel. And this evening, we're going to be talking about podiatry, exploring the scope and impact of foot and ankle care. Just a little warning, we have a couple of slides with a couple of images of wounds. They are not very graphic, but I just wanted to let you know in advance. So today's session, we'll be looking at providing an introduction to podiatry and the importance of foot and lower limb care. We will be looking at a podiatry scope and practice and specialism, so all the different things that podiatrists can do. And then we will finish with a case study to showcase the podiatric management of a couple of conditions, including assessment and interdisciplinary working with other healthcare professionals.
Thanks, Libby. So primarily, we regularly get asked what is a podiatrist, or what do we do in podiatry? So podiatrists are healthcare professions that are aligned with the Healthcare Professions Council. We come under the bracket of allied health professionals, along with physiotherapists, occupational therapists, speech and language, dietitians, paramedics. So there's a group of allied health professions that work privately and within the NHS. So we cover a wide range of issues that include common foot pathologies or problems, and also focus on the foot and the lower leg. So we focus pretty much from the waist down and specialise in that area. So key characteristics of allied health professionals is that we are specialised experts in that region. We collaboratively care with other healthcare practitioners and allied health professionals. We have a patient-centered approach, and we're autonomous practitioners. So we can make independent decisions and provide care without needing direct supervision from GPs and doctors. So once graduated, we can practice autonomously. Thanks, Libby. So the overall, the importance of podiatry is that feet are fundamental to a lot of things that we do as individuals. So foot and lower leg health is vital for overall well-being. Basically, foot and lower legs are essential for mobility, balance, and any conditions impacting on those areas can affect the quality of life of the individual. So we are focused on preventing and managing chronic conditions, so diagnosing, identifying the core complaints, assisting with pain relief and improving mobility of individuals. We provide specialist care for diverse populations, so we're looking for persons with specific medical conditions, maybe like diabetes, rheumatology, inflammatory joint conditions, cardiovascular disease, or cerebrovascular disease, or maybe specialist care for diverse populations. So we may be dealing with people with different disabilities, different specific pathologies, athletes, or different age groups. So we can work with pediatrics all the way through to the geriatric elderly populations. So the importance of podiatry is focusing on early detection and prevention of serious health issues. So if we can keep people active, we can prolong and improve quality of life by maintaining independence. And we also try and aim all the time to deliver a personalised care. So not one fit suits all. So we're constantly looking for tailoring management plans for the individual.
Regarding the roles and responsibilities of podiatrists, as Rachel mentioned, we are responsible for the assessment and diagnosis of pathologies of the lower limb and the foot. So during the assessment, we look at all the different structures of, for example, the foot or the lower leg. We look at the skin, we look at the vascular system, the neurological system, the bones, the tendons. That help us to have a good overview of all the different things that could be contributing to the pathology and help us on the diagnosis. One of the things that we do is we manage high-risk patients. These might be people who are very poorly, they might have several comorbidities, therefore they are at a higher risk of developing, for example, ulcers, which are wounds in the feet that can take a long time to heal. And if you can imagine having a wound on your foot and that is not healing, you can imagine how that can affect your everyday life. So for some people, having certain comorbidities like diabetes or peripheral arterial disease, where there is diminished blood supply to the foot, can worsen the foot health. So that's one of the things that we do. We provide treatment and management. This covers different things, like different therapies. We also are able to do some minor surgery, including nail surgery and soft tissue surgery, like some small skin surgery. And we manage wound care with different types of therapeutic treatments, which Rachel is more familiar with. You want to explain some of those, or?
Yeah. So we manage wound care in various different ways, depending on the level of complexity with the patient. So So we're assessing whether or not they've got good blood flow to the foot, and whether or not we can do things like sharp debridement, which is taking a scalpel and removing any dead and devitalized tissue from the area. A lot of patients that we deal with long-term wounds have reduced feeling to their feet, so they can't feel what we're actually doing, so it makes debridement easier, but we need to make sure that we are debriding the right people. So we would assess things like mechanical load. Is there a mechanical element to why this wound is there? Is there a vascular element? So do we need to improve the blood flow by liaising with the vascular surgeons? And we can make decisions as to if there's an infection element present. We have the ability to prescribe a few antibiotics in order to manage that infection. We've got a raft of different antimicrobial dressing products we could use. And then when you get into advanced practice, you can consider things like negative pressure machines, which causes like a vacuum to help heal the wound a bit faster, or biological agents that we can use as well. So as an advanced practitioner, you've got a whole range of products that you can decide what's the best for that person in front of you at that time.
Thank you. Some of the other things that we do is footwear assessment and orthotic prescription and manufacture. So as part of our assessment of patients, we always look at the footwear, whatever they're wearing now, and whatever they might be wearing, whether they do other activities, whether it's at home or if they do any sports. And we are able to provide some feedback and some advice on some of the features that might be more beneficial for them, like maybe in terms of cushioning or heel height or width of footwear. We also are able to design and manufacture orthoses, and we do those specifically to the presentation of the patient. So we can choose different materials that have different properties. Some of them are more cushioning, some of them could be more provide more shock absorption, and we combine these materials to provide support and to enhance movement or whatever activity that the patient might want to do. And as Rachel mentioned, we also have access to certain antibiotics. So we can administer and supply certain antibiotics, as well as some antifungals and local anesthesia that we normally use for nail surgery. If you train a little bit further, you can also do steroid injections on the joints that can be quite useful for patients that have arthritis, and that might be quite a bit of pain, and it might help them keep the mobility. Other things that we do is preventative care and education. So, for example, there might be patients who have diabetes, and they might come to clinic every 6 months or maybe once a year. And that is so we can do a foot care assessment just to check that the foot health is appropriate and ensure that they are not developing any issues, because sometimes they might develop neuropathy, which is lack of sensation. So you can imagine that if your feet are losing a bit of sensation, you could start walking on things and not noticing. So preventative care is quite important. And we do a lot of education, and this is for every single patient. So every time we have a patient in, we will be providing some education in terms of maybe the footwear they need to wear, or the management of the condition, or it could be about anything health related. Other things that we do is interdisciplinary work. So we work together with other healthcare professionals like physiotherapists, occupational therapists, and nurses, and we can refer patients to other specialists that allow us to provide a good holistic management of the patient and the condition. And finally, like all healthcare professionals, we do some administrative duties like note-taking, and also there's some people might be supervisors or team leaders, and there is a lot of mentoring as well. So when students go into placement, podiatrists are there to support students and help them develop their skills, the practical skills. So here we have a few figures, and with these, we just wanted to showcase or present a little bit the state of podiatry in the UK. These figures are from 2020. I couldn't find anything more current, but I don't think they have changed a lot. So if you look at the third column here on the number of registered podiatrists in 2020, in England, there were 9,337 podiatrists for a population of over 56 million. So as you can see, for the ratio of podiatrist population, there is a high demand on podiatry services, and this is just increasing every year, especially as certain conditions like diabetes become more commonplace, and also because we are living longer. So normally older people tend to require more input from podiatry as well. To put it into context, in 2020, in Sussex and Surrey, there were 655 podiatrists. So this is kind of like our local area, for a population of 2.9 million. So podiatry is in great need of more people to join us, because basically the demand is really, really high. But on the upside, it means that we have a job for sure. So there is no lack of jobs for podiatrists, which is not a bad thing.
Yeah, and it's similar across not just in the UK as well. So there's demand worldwide for podiatrists as well. So if you don't want to work in the UK forever, there's equal need abroad for podiatrists too.
Yeah, picking up on that, podiatry is quite a newer profession or healthcare profession, maybe compared to others. And it's a profession that it might not be as developed in other parts of the world as might be other healthcare professions. So I was reading somewhere about the number of podiatrists in Africa, and yeah, it's very, very, very low for the whole continent. Is significantly low. So we are a profession that, even though we have a bit of history, we're still quite young, and we are developing, especially in certain areas of the world. So the scope of practice, what do we do? So podiatrists can do lots of different things, and normally when you are qualified, you are just a generalist. You are able to do a little bit of everything, and then with time and experience and maybe further training, you can maybe specialize on a specific area, or maybe not. Maybe you might want to do a little bit of everything. So one of the specialisms is diabetes care and wound care, as we have mentioned already. And then there is also podiatry surgery. So podiatrists can train further and can become podiatry surgeons and can carry out complex surgery of the foot and ankle. There is also a new area of podiatry that is developing, which is forensic podiatry, that looks into things related to maybe legal issues. This can be like identification of people through gait analysis of video images, to attending court to provide evidence as because of your specialism in the field about maybe whatever it is, whether it's an injury or anything like that. And we briefly mentioned biomechanics and orthotic prescription. So biomechanics is the analysis of human movement, like walking or maybe running. And podiatrists, we are trained to do that and also trained to design and manufacture orthoses. There is also linked to that, there is sports podiatry and performance management, that maybe this is a little bit more focused on those who are doing sports at a professional level. Other areas of podiatry include pediatrics, that is specializing in children care, like foot care, and this is because there are specific conditions that might be present in children that are not present in adults. And there is also rheumatology and dermatology that deals with things about the skin, any conditions presenting on the skin. We've got also elderly care, health promotion, and patient education. And part of our scope of practice, as mentioned before, is the use of prescription-only medicine that we have access to, and also local anesthesia and steroid injections. Other things that podiatrists can do is they can work in education and academia, like Rachel and I are doing, and also in research or service management. So a lot of podiatrists might start, for example, working in clinic. Imagine in the NHS, there might be clinical podiatrists, and then slowly might be going up the bands until they get to more of a senior management position. So we're going to briefly comment on a couple of the specialisms, which are the most common ones. So we have musculoskeletal, biomechanics, and sports podiatry. These are specialized fields that focus on the assessment, diagnosis, and treatment of foot and lower limb conditions to improve movement and performance. So it's everything related to movement and to maybe sports. So it's all related to conditions that are affecting the joints, the tendons, and the muscles, and that might be affecting how the person is moving. Part of that includes injury prevention, pain relief, and improved performance. And normally podiatrists who are specialists on this area, they might work on a specialist clinic that specialize on musculoskeletal conditions, or sometimes they might work in sports team or sport clubs, and sometimes they might work in sporting events like this one here. This is one of our students at the Brighton Marathon. This is something we do because, as you can imagine, after running a marathon, the feet can be in not a very good shape.
Libby. So, as Libby mentioned, diabetic foot and wound care is an area that is increasing. So, as mentioned, the population of the world is increasing, and we are all, and the majority are living longer. So as our ages increase and as more people develop comorbidities, there's more people at risk of developing foot and lower leg problems. So at present, we've got more than 5 million people living with a diabetes diagnosis in the UK. So well-controlled diabetes is great, and there's lower, there's the usual risk of developing complications as that of the normal population. But persons with uncontrolled blood sugar levels and diabetes can develop more complications to the foot and lower leg. It's also estimated by Diabetes UK that at the moment there's 12.1 million adults in the UK are living with undiagnosed diabetes, or they're in that pre-diabetes phase and they've not yet discovered that. So they're at risk of developing diabetes with current lifestyle choices and Western living. So basically what we're aiming at doing, education is a key one in this one, is that we're trying to screen persons with diabetes as soon as possible to identify their risk of developing complications. So what we know is that poorly controlled blood sugar levels can accelerate things like that lack of sensation developing in the feet, and it can speed up things like it can speed up the development of reduced blood flow to the foot. And then things like the neuropathy and the reduced blood flow contributes together in order to put the foot at higher risk of developing wounds that won't heal, which will then turn into ulceration. And then if we've got an ulcerated foot, we've got a break in the skin that's at risk of an infection. And then if we've got an infection, then potentially there's that risk of a spreading infection and a bone infection, or potentially leading to an amputation. There are other conditions that are linked with diabetes, such as the Charcot foot, which is typically affects a foot that has dramatically reduced sensation, so really reduced nerve supply. It doesn't always happen with people with diabetes. It can also happen with anyone that has reduced sensation to a foot. So that could be through road traffic accidents, or vitamin B12 deficiency, and lots of other little medical conditions, or not little medical conditions, or other medical conditions. So anything that can damage those nerves can potentially put the foot at risk. So as you can see from that sequence of events, if we've got a medical condition that is damaging the nerve supply, or it's damaging the blood supply to the foot, and it's putting it at risk of ulceration, those complications can lead to significant disability and reduced quality of life. So if we have somebody with ulceration on the foot, we're going to have to reduce potentially maybe the activity, or ascertain the amount of offloading that person needs, and that can dramatically affect how the patient feels, really, the quality of life impacts and the psychological impacts of a chronic wound on a patient is very high indeed. So obviously we want to get the person mobile and active as soon as we can, and reduce those impacts and reduce the disability that potentially could happen. Thanks, Libby. Next. Lovely. So we're looking at preventing problems. So every patient contact, we are striving to make every contact count. So we're looking for any gaps in the patient's knowledge as an understanding as to what we're trying to achieve, and what's the rationale for that, and what does the research say. So we're educating people on, are they able to do proper foot checks for themselves? Are they looking after their feet appropriately in the lower leg? Is the footwear suitable? Do we need an orthotic? How to check their feet regularly to make sure that there's no new areas of damage, and things to look for in order to prevent injuries and reduce the chance of an infection if we've got a break in the skin. I mean, research has shown that for some people, lifestyle interventions such as diet, activity, and weight management can reduce the chance of type 2 diabetes by about 50%. So sometimes a lot of our patient appointments are focusing on helping patients realise what the impact of lifestyle modifications can be, and helping maintain activity levels even whilst we've got a wound on the foot. So as you can see, this person's got they've got an ulceration on the bottom of the ball of the foot, the first metatarsophalangeal joint. They've already had some surgery to remove the third digit. So what we're trying to do is preserve function and maintain a functioning foot on the bottom of the patient, and allow them to keep active and keep mobile. So what we might start off with is temporarily offloading the area with semi-compressed felt, whilst we're in the background taking the measurements for an orthotic or a bespoke device to go in the patient's shoe. It might be that the footwear that the patient has isn't similar, it's not large enough because they've got these surgery modifications to the footwear, and they may need made to measure footwear that will accommodate their foot shape. So what our role is looking at, sorry Libby, we're looking at those wounds. We're assessing to see if they're infected. If they're infected, we're doing the assessments and tests to take wound samples and see which microorganisms are there, and then we're tailoring our prescriptions of antibiotics or antimicrobials to best suit what that infecting organism is. So we would debride it, appropriately offload it, and prescribe the required medication to the patient. Okay, so as mentioned, it's not, diabetes is a large proportion of the NHS caseload in the NHS, but it's not all of our caseload. So we treat a lot of other long-term conditions. So as I mentioned, reduced blood flow to the foot is a common long-term condition that we have a lot of dealings with. So things like atherosclerosis and arteriosclerosis, where those arteries become narrowed and reduce the blood flow to the foot. Any region of the foot that has reduced blood flow is at increased risk of damage and potential ulceration. So we're screening patients and assessing patients regularly for deterioration in blood flow. We have a very good anatomical knowledge of where the blood vessels and the nerve vessels are going in the lower leg, and we're sort of key at screening for peripheral arterial disease and then potentially flagging anybody identified with issues onto the vascular team and back through the GP. So anybody with chronic peripheral arterial disease or sensory neuropathy or motor neuropathy are going to require ongoing podiatric care. So these long-term conditions are people that we can't discharge from the department, so demand is only going to increase as we live longer. So the benefits of being a podiatrist is that we definitely make a difference. Every day you make a difference. We save limbs and we save lives of patients. So you would be trained to identify serious spreading infection, critical limb ischemia, and we have same-day referral pathways in order to get those patients to the care that they need on the same day. So we save lives on a regular basis, and we definitely save limbs and keep legs on patients because we get them the treatment that they need at the right time. Career flexibility and opportunities I would advocate. So basically the podiatry as a profession is really flexible. So you can work for the NHS full-time, you can work for the NHS part-time, you can work privately, full-time, part-time, you can do a mixture of both. As your life progresses, you've got that flexibility of working full-time, dropping to part-time for a bit, going back up to full-time again. And as we mentioned, those different specialisms allow you to identify or try different specialisms and see where you want to end up working. So there's plenty of opportunities, and with the podiatry numbers, or the qualified podiatrist numbers, and the number of jobs out there at the moment, there's plenty of opportunities for you to move and travel and try different places to work. So there are those global opportunities, there's career progression. So typically, I think we've got a slide in a bit that you would start as a band 5 podiatrist, maybe in the NHS, and then you can progress to a band 6. Band 7 tends to be a team lead or a specialist post, and then you can go on to then develop into the band 8s, which are the specialist practitioners or the consultant podiatrists. And then you could potentially go into podiatric surgery, research, education, wherever you like. So it's definitely diverse and rewarding work. No 2 days are the same. No 2 patients are the same. So you always get patient satisfaction and a job well done by the end of a day. And the ability to get that work-life balance and work when you want to work is brilliant.
Right. So now we're going to be looking at a case study of a patient developing a couple of health conditions, and we're going to take you through the process of assessing and managing the patient, so you can see a little bit in how we put into practice or how we deal with patients from the podiatry side. So the case study is about Alex, 48 years old, who attends the clinic due to a painful toe. And on assessment, you identify he has an ingrown toenail, which will require nail surgery. So ingrown toenails are very common, and especially in male teenagers, but they can happen on younger patients and also older patients. And sometimes some conservative treatment is enough to manage the condition, and then it self-resolves. But in some cases, nail surgery is required, like in this case for Alex. So what is nail surgery? So nail surgery is a minor surgical procedure where we remove part or the whole nail. So during nail surgery, we start by administering some local anesthesia. We normally inject on one side of the toe and then the other side, and we wait for the toe to go numb. Before that, obviously, we need to do our checks and calculations to ensure we know how much anesthesia we are able to administer. When the toe is gone numb, we will clean it, and then we will put a tourniquet, which is this plastic band. The tourniquet allows us to work and remove some of the nail with minimal bleeding. So it allows us to see things better, and also is not too messy. From the moment we put on the tourniquet, we only have 20 minutes to complete the procedure. And sometimes we just might remove part of the nail, so just one side. Sometimes we might do bilateral, so a little bit of one side or the other side that are curving into the skin. And in some cases where the nail is really curved and maybe really small or really thick and causing a lot of damage, we might remove the whole nail. In most cases, we use chemical matrixectomy, which basically we use a chemical. And on this picture, you can see this person has a little, it's like a cotton bud that has a little bit of phenol, a chemical that we use that we insert into the nail bed, and we get to the matrix once we've removed the bit of the nail, and that will stop the nail from regrowing. So basically, as we have removed this part of the nail, then we put the phenol, and then that means that there is a very small likelihood of regrowth. And sometimes we might not use phenol in some cases. For example, if somebody has had trauma and they have a very bad ingrown toenail, but you think it could get better, you might maybe do a bit of surgery and then not use phenol and see how it grows. And the recovery is quite quick. So once we've done the surgery, so we put the tourniquet, remove the nail, part of the nail, we apply the phenol, and then we take off the tourniquet and dress it. Normally patients have to return to clinic 1 or 2 days later for a review to ensure that everything is okay. And after that, they normally just self-manage by changing the dressing. And as I said, the recovery is quite quick. Patients tend to heal in between 4 to 12 weeks, and younger patients tend to heal quicker. However, that depends on following the advice. So in terms of the post-op care and also the activity levels. So here, if anyone wants to know a little bit more about nail surgery, you have this QR code. It will take you to a video by the Royal College of Podiatry. So you can watch and learn more about it. So Alex will need nail surgery, but before we do nail surgery and before we do anything, we have to carry out a medical history, and this is quite holistic. We will be looking at medication to identify what medication he's taking, and if there is any medication that might interact or might lead to adverse reaction. For example, if we are using local anesthesia or if we are supplying any antibiotics. We also will want to know if Alex has any other health conditions, for example, diabetes or peripheral arterial disease, where the blood flow to the foot is reduced. So if, for example, Alex was to have diabetes, we will need to know what his sugar levels are, because if they are too high, it will mean that it will take him longer to heal, and then he will be at higher risk of infection. So in that case, we will have to postpone the surgery until his blood sugar levels are more controlled. We also consider activities, so their occupation. We might have patients that use steel toe cap boots, for example. So we might have to take that into consideration, or maybe the type of occupation they have. So if they spend a lot of time standing up, or if, for example, if Alex is a swim teacher, then maybe we might have to consider how he's gonna be able to heal if he's in an environment where his wound can get wet. And the same goes for hobbies and sports. Other things that we need to consider, for example, is are they going to go on holidays, or are they planning to do anything outside of the normal, because this could affect their recovery. And just as an example, I had a patient who had an ingrown toenail, and she was a very good cricket player. And because it was mid-season, we couldn't do the surgery then. So we did a little bit of conservative treatment and waited until the end of the season when we carried out the nail surgery, and then she had enough time to heal properly. And then other things that we have to assess are things like social history. This includes environmental influences, living conditions, and self-care. This is key because sometimes our patients need to, in this case, Alex, for nail surgery, will have to redress his toe. So if he's unable to do that because maybe he's got eyesight problems, or because he's unable to reach, or because he's not able to understand what he needs to do, we will have to assess that and maybe find a solution so everything is okay and he can be able to have the surgery. In terms of Alex reports with numb feet and altered sensation. So in that case, apart from maybe considering nail surgery, we need to carry out a full assessment of the foot and the lower limb. And things we look at, we start looking at the skin. So we look for anything that is maybe abnormal. And because he had a little bit of a growth on the side, I'm going to go back to the slide here. We will want to identify if this is normal for an ingrown toenail, or if this could be something else that we might need to consider and maybe refer for, like an unexpected growth. Then we also look at the musculoskeletal system, so the bones, the joints, the tendons, because there could be things in the musculoskeletal system that could be contributing to the development of the condition. So, for example, if a patient has a problem with a joint, it might mean that they are overloading or compensating with one part of the foot, and that means that maybe they're putting a lot of pressure on the side of the toe and causing the ingrown toenail. And then other things we would need to consider is the vascular assessment. So we will be looking at the blood flow to the feet and the venous return to ensure that the wound could heal properly, and also the neurological status to ensure that he's able to feel everything and that he's not at risk of developing other conditions like an ulcer. We would also have a look at his footwear, because sometimes it can be footwear that can contribute to the development of an ingrown toenail. And this is very common in younger people because they might grow very quickly, quicker than they expect, and they might be wearing shoes that might be a little bit too tight. So in this case, we will look at the vascular assessment. The vascular assessment, for the vascular assessment, we look at loads of different things, like you can see here. We palpate the pulses on the feet with our hands, with our fingers first. These help us to locate them and to have an idea of how good the blood supply is. And then we use a Doppler ultrasound to listen to these pulses and ensure that they are good, there is a good blood supply to the feet. However, there are other things that we look for. We might look for the color. So healthy feet tend to look a little bit more pink or not too pale. We might be checking temperature. Normally temperature goes warm to cold when you go down from the lower leg to the toes. We might look for other signs of other complications like intermittent claudication. That's when the blood flow supply to the foot is limited, and things like varicose veins. So as you can see, the vascular assessment is quite complex, and it's something that we do very quickly. Even though there is a lot of different things to look for, this might take just, I don't know, 3 minutes, 3-4 minutes approximately. Okay, so when we do the vascular assessment, as I mentioned before, we use the Doppler ultrasound, and we put it on 2 different areas of the foot to listen to the pulses. And I wanted to show you a couple of examples, but it's playing up a bit with me. So we're gonna do it like this. So we're gonna play this one first. So this is just to show the difference in the sounds depending on the quality of the blood supply to the foot. So the last one is where you have a triphasic pulse, that you have all these 3 sounds, and that is the best type of pulse that we can hope for. And this is what you would typically find in younger people of your age. So you have these 3 sounds. Having 2 sounds is also good. It means that there is a good blood supply. So this is the 2 sounds. And this is where there are monophasic pulses. So this is a monophasic pulse where there is just 1 sound, and it means that the blood supply might be diminished. Okay, so I'm going to move on to the next one.
So I'm just mindful of the time as well.
Yes. I've
So
realized.
we're going to whiz through these last few slides. So as well as the vascular assessment, because Alex has presented with altered sensation to his feet, what we need to do is assess which branches of the nerve supply are affected. So you'll know that we've got motor, sensory and autonomic. So we're looking for protective sensory changes by the use of the monofilament here that's indicated in the pictures. So we test all the dermatomes of the foot, which are all the nerve regions that different branches of the nerves to the lower leg are innervating, so that we can try and get an idea of if it's a specific nerve branch that is affected, or if it's just the sensation to the whole foot, or if it's just one or two dermatomes that are affected. We look for muscle strength and power. We check reflexes to see the motor side of the nerve tree. And then we also look for the autonomic nervous system and see if there's any changes in sweating, skin hydrosis, and then arteriovenous shunting, because that's automatic control of the body. So we're looking for those sorts of elements. So after we finished our assessments for Alex, what we found is that there's no arterial insufficiency or venous insufficiency for Alex. We've got a reduced sensory score with a 10-gram monofilament of 2 out of 10, which basically means he really can't feel his feet very well. So that will put his feet at risk of banging his feet, standing on something, not being aware that he's damaged them. The MSK biomechanical observations have got normal power and tone. He's got good joint range of movement, joint function, so we can rule out some of the biomechanical causes of his ingrown toenail, and the footwear is appropriate for his current foot shape. And then other than the ingrown toenail and that nail skin break, there's no dermatological conditions that we've observed of note, and the lump in the ingrown toenail is what you would expect for somebody with hypergranulation tissue of an ingrown toenail. So we're going to book this person for nail surgery with the phenolization and that chemical matrixectomy, as Libby said. And that surgery is usually performed by a band 5 or 6 podiatrist. So you can be performing those surgical procedures from as soon as you graduate. That heals well with no complications, and then typically what we would be looking at, because of this altered sensation in the feet, is that we would follow up that person in the community every 3 months. So it would be likely that a band 5, band 6 podiatrist would follow them up 4 times a year, and they would be educating in lines of emergency contact if you get another break in the skin, if you suddenly present with a hot swollen foot, you've got any change in signs or symptoms to the lower leg, because they are at higher risk of developing complications. So what may happen is that the patient contacts. So in our case study, what we've got here is that suddenly Alex contacts down the line, and he attends his normal community podiatry clinic with a sudden onset hot swollen foot. Now this foot might present as if you've twisted your ankle or you've done a lateral ankle sprain, and we need to be thinking about musculoskeletal conditions and what's the history. So we know that Alex can't feel his feet very well, and he's not been able to feel his feet for a while, but today it's suddenly painful on that right side. We can't feet, and then therefore no red flag sign for further investigation. Can't remember any trauma, and he's walked for normal. So what we would be thinking of is other medical condition diagnoses that may have caused us this to happen. So we're trained to recognise something called Charcot foot. So if a patient presents like Alex has with diabetes or a nerve or an insensate foot, a foot he can't feel, and a sudden swollen hot foot and he can't remember why, and there's no injury, we would treat as a Charcot foot until we're proven otherwise. So this is an example of the different specialists that would then become involved. So your community podiatrist would screen and identify the neuropathy and query a Charcot foot. Then we do a same day urgent referral to a multidisciplinary team specialist podiatrist, which is band 7 or 8. And then they would see the patient within 24 hours to then see further tests. So we might get an x-ray to have a look for fractures, or here you can see we've got a ligament rupture and we've got movement of the second metatarsal head. Don't know if my mouse works on your screen, but yeah, the second metatarsal has shifted there. So if we don't protect that foot, it will deform, and when the person tries to walk on it, it will be problematic in future. So what the specialist may do is put total contact casting on, as in the picture on the very right hand side, and we manage this patient until the changes within the foot have settled down and they're safe to then potentially come out of the cast and go into custom made footwear. So once we're progressing, the assessment and management would be shared care between the foot protection team, which is usually a band 6 podiatrist, and the specialist team, and then that patient will be monitored until resolution. Thanks. It's a bit of a whirlwind, sorry, but we're on the last few minutes. Okay, go on, Libby.
Okay, so in summary, podiatry is an essential healthcare profession focusing on the diagnosis and treatment of lower limb pathologies, including the lower limb, the ankle, and the foot. There is a great scope of practice, including prescription-only medicines, nail surgery, wound care, diabetic foot care, musculoskeletal conditions. So we do a lot. We work with other healthcare professionals and as part of the multidisciplinary team to offer best patient management. And basically, because there's so few of us and there is such a high demand, there is excellent employability. There's lots of diverse specialisms and global opportunities, and life-work balance is quite good because you can adapt your work to your lifestyle. Okay, I think that's pretty much it. So have you got any questions?
Thank you so much, Libby and Rachel. That was a really comprehensive, informative talk. I really enjoyed it, and I think the audience did as well. We've got time maybe for just a couple of quick questions, if that's all right. Cool. Someone has asked, what is something that really affects podiatric health that you don't think people realise enough?
I think I would probably say people tend to ignore their feet until they really are problematic. So, you get the slightest hint of toothache, people are at the dentist straight away. People tend to ignore their feet until it really is a problem. And sometimes, as with everything, the earlier you can pick up a condition, the better the prognosis is and the faster you'll get better. So I think people just tend to ignore their feet a bit too much.
Yeah. Did you want to add anything, Libby?
No, I completely agree with that. I think people, some people might think that, oh, feet, they are not very nice. So they also have quite a bit of, they're very self-conscious when they come into clinics, that they always say, oh, my feet are horrible. And it's like, actually, your feet are normal. And I've seen a lot worse. So, yeah, I think people should be, should be attending clinic or seeking advice when needed without any self-consciousness or any issues, because as any other healthcare professional, we've seen it all. And for us, it's just another part of the body, really.
Brilliant. Thank you. Yeah, so the message is, everyone, pay attention to your feet and don't be self-conscious. Someone else has asked, what's the most challenging part about being a podiatrist?
What's the most challenging part? I would say, for me, with the wound care management side of things, I would say juggling people with really complex comorbidities. So if you've got individuals that have got diabetes and rheumatoid arthritis and poor blood flow and feet that they can't feel with loads of medication, that can get quite complicated. And you get quite invested with these people as well, because you tend to see them weekly for a long time. So you're trying to do the best that you can, and you don't want to miss anything, and you don't want them to get an infection, and you're doing everything you can to keep this person mobile and active, and not end up with an amputation. So, you know, that at times can get quite intense, but that they're sort of a small percentage. There's lots that go really well, and there's lots that you can make a really big difference, and seeing them quickly and getting the offloading right and the medication right is really, really rewarding. So, you know, those really complicated ones are outweighed by a lot of people that you can help quite quickly.
Thanks, Rachel. Yeah, I was so interested. I hadn't realized like how yeah, like you say, like how much of a difference it actually makes taking care of your feet, and how much, you know, as podiatrists you can contribute to the overall well-being. So that's really brilliant. Libby, what about for you?
From a musculoskeletal point of view would be providing advice, and maybe people not following the advice because they are very invested in the sport or their activity, or providing advice about footwear. And there is so much that you can do in terms of treatment and advice, but patients need to take responsibility for their health, and sometimes that can be a little bit difficult.
Yeah, absolutely. Well, thank you both. I don't want to run over too much in case you need to run off anywhere. I've just noticed though, I have got a couple of questions about if people are interested in doing the course. Some people have had asked some questions about kind of entry requirements and information about placements and things. Would it be best for me to maybe post in the chat a link to the course webpage on the university website?
Well, I mean, Libby, you're the admissions tutor, aren't you? So you're...
Yeah. Well, I mean, if they want, they can contact me directly. I don't know if you can see it now, but that is my email at the bottom of the screen. And so I am the admissions tutor for the BSc course. You can just send me an email with any questions, and I'll be happy to answer. And if you want to have a chat, I can organize that as well. So you just send me an email and I'll be happy to answer anything.
That's brilliant. Thank you so much, Libby. So yeah, anyone in the audience, I saw there are a couple of questions about getting onto the course. So if you'd like to send your question to Libby, she'll be able to answer that for you. Sorry, we don't have time for more questions, but thank you so much again to our brilliant speakers. It was a really fantastic talk. Thank you everyone in the audience for coming and joining us again this month, and hopefully see you for the next one.